this module, we are going to deal with lung volumes and capacities. So here, the first test is the spirometry. Spirometry is the most common test of the pulmonary function tests, and the spirometry test is performed using a device called spirometer, which comes in several different varieties. The spirometers display the following graphs called as spirograms. So as you can see over here, that the volume time curve showing the volume in liters along the y-axis and the time, that is seconds, along the x-axis, and a flow volume loop which shows the rate of airflow on the y-axis, the total volume inspired and expired on the x-axis. Spirometry is indicated for the following reasons. It is mainly to diagnose asthma and to measure bronchial responsiveness in patients suspected of having asthma, and also to differentiate between the obstructive lung disease versus restrictive type, and to estimate pre-operative lung function before anesthesia or cardiothoracic surgery. So the forced expiratory maneuvers are done while conducting spirometry test. This may aggravate the following medical conditions, and spirometry should not be performed when the individual presents with hemoptysis of unknown origin, pneumothorax, thoracic abdominal or cerebral aneurysm, cataracts or recent eye surgery, recent thoracic abdominal surgery. All these are the contraindications for the spirometry test. So what is the procedure of this? The lung volume is nothing but displacement of air volume during inspiration or expiration. So if you see the lung volumes one by one, the first one is the tidal volume. So it is the amount of air that moves into the lungs with each inspiration, or amount of air which moves out of the lung during each expiration during normal quiet breathing. This is called as tidal volume, right? And the amount of air which is inspired during quiet breathing, that is inspiration as well as expiration, is 500 ml, and it is approximately between 500 to 700 ml. And the next one is the inspiratory reserve volume. So after tidal volume, which means after a person inspires 500 ml, the maximum amount of air the person inhale is called as inspiratory reserve volume. So whenever the patient is inspiring air after the tidal volume by maximum effort, how much amount of air is entering into the lungs, we will get the value of IRV, which is inspiratory reserve volume, and which is approximately 3,300 ml. So inspiratory reserve volume is 3,300 ml, and it is ranging from 3,100 to 3,300 ml. And the next one is the expiratory reserve volume. So the volume expelled by an active expiratory effort after passive expiration is called as expiratory reserve volume, which means we know that during tidal volume, the normal amount of the air which comes out is 500 ml, right? So a person is taking 500 ml inside and he is exhaling 500 ml outside. So after exhaling the inhaled 500 ml outside, the maximum amount of air which can be exhaled from the air which remains in the lungs is called as expiratory reserve volume, and that is 1000 ml. So here, what is the residual volume? So the air which is left in the lungs after maximal expiratory effort, which means after expiratory reserve volume, some amount of air also leaves the lungs with maximum forceful expiration from the amount of air which is present inside the lungs. So This is nothing but called as the residual volume, and it is 1200 ml. So these are the lung volumes. The tidal volume is 500 to 700 ml, and we will consider it as 500 ml. And the inspiratory reserve volume is 3300 ml, and the expiratory reserve volume is 1000 ml, and the residual volume is 1200 ml. These are the volumes of the lungs during inspiration or expiration. Now, what are the lung capacities? First is the inspiratory capacity. So what is the inspiratory capacity? The maximum amount of air that can be inspired from the end expiratory level. So the maximum amount of air that can be inspired from the end expiratory level, that can be calculated as inspiratory reserve volume plus tidal volume. So tidal volume is 500 ml. I am taking 500 ml air inside. After this, the maximum amount of the air which I can take, that is IRV, that is 3300 ml. So what is the inspiratory capacity? I am in a position to take tidal volume, that is 500 ml. And after 500 ml, with maximal forceful inspiration, I can take 3300 ml. So what is the inspiratory capacity of the individual? It is 3800 ml. So that is the inspiratory capacity, and it can be calculated with the formula, that is tidal volume plus inspiratory reserve volume. And the next capacity is the functional residual capacity. So the volume of air remains in the lungs after expiration of a normal breath, which means a person is taking 500 ml of air inside, that is 500 ml of air is going inside, and the 500 ml of air is coming outside. So when there is a normal inspiratory as well as expiratory process, the amount of air which remains in the lungs still during the normal tidal volume, that is inspiration as well as expiration, is called as functional residual capacity. So what is the functional residual capacity? That is approximately 2200 ml is called as functional residual capacity. Now next, the very important one is a vital capacity. So what is the vital capacity? So the maximum amount of air that can be expired from the fully inflated lung or maximum inspiratory level is called as inspiratory capacity. This will represent tidal volume plus inspiratory reserve volume plus expiratory reserve volume. We know that the tidal volume is 500 ml, the inspiratory reserve volume is 3300 ml, and the expiratory reserve volume is 1000 ml. So the total is 4800 ml is the vital capacity. And now, what is the total lung capacity? So the total lung capacity can be calculated by the tidal volume, inspiratory reserve volume, expiratory reserve volume plus residual volume. So we can say that the vital capacity plus residual volume, that is 4800 ml plus 1200 ml, which is equal to 6000 ml. So 6000 ml is the total lung capacity. So this is what you need to know about the lung volumes as well as lung capacities. Now let us talk about the dynamic measurements of lung volumes and capacities. And the first one is the forced vital capacity. It is the largest amount of air that can be forcefully expired after the maximal inspiratory effort. So the fraction of vital capacity expired during the first second of a forced expiration is referred to as FEV1. So the forced expiratory volume in the first second is called as FEV1. Here the FEV1 to FVC ratio, that is FEV1 by FVC, is extremely useful tool in recognizing or diagnosing the chronic obstructive pulmonary airway diseases. So the next is the obstructive disorders, that is COPD, mainly results in a marked decrease in both FVC as well as FEV1 FVC ratio, but whereas in restrictive type of disorders, there will be a loss of FVC without change or without loss in FEV1 FVC ratio. And the next, now let us talk about the difference between the vital capacity and the forced vital capacity. So the two types of blows are done during spirometer. First is the relaxed or slow vital capacity, that is VC, and after is the forced vital capacity, which is FVC. So the vital capacity starts with the full inspiration and the patient blows out in a very slow and relaxed manner until the lungs are emptied. But the forced vital capacity also starts with full inspiration, but after that the patient blows out very fast and hard until the lungs are completely empty. So a minor difference occurs in the vital capacity if the forced maneuver is done instead of opting the slow maneuver in normal individuals. On the other hand, this occurrence has been exaggerated for the patients with a case of airflow obstruction, where the difference elevates in proportion to the degree of obstruction. So there is a trapping of air when there is a very major difference among vital capacity as well as FVC. And the next is respiratory minute volume. It is a volume of gas inhaled, that is inhaled per minute, or the volume of gas exhaled per minute from the person's lungs is called as minute volume. So RMV, that is respiratory minute volume, is normally 6 liters. So for example, if you take as a normal resting condition, that is 12 breaths per minute. Each breath, that is tidal volume 500 ml, and 12 breaths 500 into 12 is equal to 6 liters. So the respiratory minute volume is 6 liters. And the next is, what is the maximal voluntary ventilation? So the largest volume of gas that can be moved into as well as out of the lungs in minute by the voluntary effort. For example, the normal values, which ranges from 140 liters per minute up to 180 liters per minute for a healthy adult man. What is the clinical significance? In normal person, that is during normal breathing, 6 liters of air moves in and out of the lungs per minute under resting conditions, and this can go up to maximum of 140 to 180 liters per minute in healthy adults. So what is the limitation of spirometry? So here, a spirometer can measure only changes in the volume. It cannot measure the residual volume. For the calculation of the total lung capacity and FRC, the value of RV is required. So what are the tests which are used to measure residual volume? Or plethysmography, helium dilution method, and single breath nitrogen test. And the first one is plethysmography. So plethysmograph is an instrument for measuring changes in the volume within an organ or the whole body. So the organs studied with the help of plethysmography are limbs. The plethysmograph devices are attached to the arms, legs, or other extremities and mainly used to determine circulatory capacity. And next is genitals. So what is a penile plethysmograph? This device is used to measure changes in the blood flow in the penis. And the third one is the lung body plethysmography. So what is the principle, which is the Boyle's law? The absolute pressure exerted by the given mass of an ideal gas is inversely proportional to the volume it occupies if the temperature and the amount of gas remains unchanged within the closed system, is called as Boyle's law. We know this, right? And what is the procedure? The test subject is placed inside the sealed chamber, which is the size of a telephone booth with a single mouthpiece. At the end of normal expiration, the mouthpiece is closed, and the patient is then asked to make an inspiratory effort. As the patient tries to inhale, the lung expands and decreases the pressure within the lungs and increasing the lung volume. This in turn increases the pressure within the box since it is a closed system and the volume of the box compartment has decreased to accommodate the new volume of the subject. So what are the uses? Body plethysmography is used in measurement of FRC, which is functional residual capacity. So balance between the chest walls is desired to open and the lungs is desired to collapse. The amount of air in the lungs after expiring a normal breath. So if you talk about the functional residual capacity, it is the volume of air present in the lungs at the end of passive expiration. So at functional residual capacity, the opposing elastic recoil forces of the lungs as well as the chest wall are in equilibrium, and there is no exertion by the diaphragm or any other inspiratory muscles. So the transrespiratory pressure is approximately 0. What is the significance? Respiration is a cyclic, but flow of blood to the pulmonary circulation for gas exchange is continuous. If there is no FRC, intrapulmonary shunt is created and deoxygenated blood enters the circulation. For example, in conditions like emphysema, FRC is increased, leading to broader chest, that is the dilated chest, or we can say barrel-shaped chest, which is seen in emphysema. And what is the total lung capacity? We know this. It is the inspiratory reserve capacity plus FRC. And the inspiratory reserve capacity can be determined by spirometry. Next is airflow resistance. The resistance can be calculated by pressure divided by airflow. And this is the formula of the resistance. Normal airway resistance is 1 centimeter water per liter. And the resistance airway is low during laminar flow and it is high during turbulent flow. In what conditions there will be an increased airflow resistance? That is low lung volume or forced expiration or more dense or viscous inspired gas or airway in series, medium to large bronchi. In all these conditions there will be an increase in the resistance. And the decreased resistance is seen in high lung volumes during inspiration. Less dense or viscous gas are the ones where you can see decreased resistance, and also it is seen in the smaller airways as well as in the parallel airways. And after discussing the resistance, next a very important method which is called as a helium dilution method. This helium dilution method is a technique, a closed circuit system where the spirometer is filled with a mixture of helium and oxygen. And the amount of helium in the spirometer is known at the beginning of the test, can be calculated as C1. And the patient is then asked to breathe, that is normal breaths, in the mixture starting from FRC. So the spirometer measures helium concentration. So the helium spreads into the lungs of a patient and settles at a low concentrations, that is C2. Because there is no leak of substances in the system, the amount of helium remains constant during the test, and the FRC can be calculated by using the following equation. C1 versus V1 is equal to C2 versus V2. And by this formula, C1 into V1 is equal to C2 into V1 plus FRC. And FRC can be calculated finally as C1 V1 divided by C2 minus V1. So here V2 is equal to total gas volume, that is FRC plus volume of spirometer. V1 is equal to the volume of gas in the spirometer. And I already told about C1, which is the initial helium concentration which is known, and C2 is the final helium concentration which is measured by the spirometer. So, in patients with obstructive pulmonary diseases, the measurements of the helium dilution technique are not reliable because of the incomplete equilibrium of the helium in all areas of the lungs. In such cases, it is more accurate to use a body plethysmograph. Next is nitrogen washout method. What are the uses? It is used for the calculation of the dead space, and the parameters are related to closing of airways and also calculation of residual volume. And the first one is the dead space. So we have two types of dead spaces. One is the anatomical and other one is the alveolar dead space. So what is the anatomical dead space? Because the gaseous exchange in the respiratory system occurs only in the terminal portion of the airways, the gas that occupies the rest of the respiratory system is not available for the gaseous exchange with pulmonary capillary blood. Normally, the volume that can be expressed in milliliters. So the volume of this anatomical dead space is approximately equal to the body weight in pounds. As an example, in a man who weighs 150 lb, that is 68 kgs, only the first 350 ml of the 500 ml inspired with each breath, at the rest mixes with the air in the alveoli. So conversely, with each expiration, the first 150 ml, which is already present in the conducting zones, expired is that occupied as a dead space. And the last 350 ml of the gas comes from the alveoli. So this is what is called as anatomical dead space, and it is 150 ml. What is the alveolar dead space? In diseased states, no exchange may take place between the gas in some of the alveoli and the blood, and some of the alveoli may be overventilated. So here, these are the alveoli. So whatever may be the diseased state, whatever may be the problem, the exchange of gas, that is oxygen or carbon dioxide, is not taking place between the alveoli as well as the blood, or from the blood to the alveoli. So the air is trapped inside the alveoli. So this air is not taking part in the gaseous exchange. So there will be elevated alveolar dead space. Generally, every alveoli in the healthy individual are functional. So there will be no alveolar dead space. So what is alveolar dead space means? We can calculate it as the anatomical dead space plus physiological dead space, or alveolar dead space can be calculated as alveolar dead space. But in general normal conditions it is zero, because every molecule of air which is present inside the alveoli take part in the exchange of gases. Only in the diseased conditions, the air which is present in the alveoli is not taking part in the exchange mechanism. That is the reason the trapped air inside the alveoli can be added with the anatomical dead space. So overall the alveolar dead space concentration or the value increases. So in general we can say that the normal volume of gas in non-perfused alveoli and any volume of air in the alveoli in excess of the necessary to arterialize the blood in the alveolar capillaries is the part of alveolar dead space. So the physiological dead space is equal to anatomical dead space plus alveolar dead space. So we know that the physiological dead space is equal to 150 because the alveolar dead space is 0. And whenever the physiological dead space is greater than anatomical dead space, we can say that the individual is suffering from lung disease, example pulmonary embolism. And the next is single breath nitrogen test, Fowler's method. From mid-inspiration, the patient takes a deep breath as much as possible of pure oxygen and then exhales steadily while the nitrogen content of the expired gas is continuously measured. the initial gas exhaled, that is in the phase 1, is the gas that filled the dead space and that consequently contains no nitrogen. This is followed by a mixture of dead space and the alveolar gas, that is phase 2, and then by the alveolar gas is phase 3. So the volume of the dead space is the volume of the gas that is expired from peak inspiration to the mid portion of phase 2. So the single breath nitrogen curve explains that from mid inspiration the patient takes a deep breath of pure oxygen, then exhales steadily, and the changes in the nitrogen concentration of the expired gas during the expiration are shown on the graph. And with the various phases of the curve indicated by the Roman numbers, notably region 1 is the representative of the dead space, and from 1 to 2 is the mixture of the dead space as well as alveolar gas, and the transition from 3 to 4 is the closing volume, can be represented as CV, and the end of 4 is the residual volume called as RV. So what is the Bohr's equation? It calculates the amount of physiological dead space in a person's lungs. It differs from the anatomical dead space as measured by the Fowler's method, as it includes alveolar dead space component. It is the ratio of the physiological dead space to the total tidal volume, can be represented by this formula. And next, what are the parameters related to closing of airways? The first one is called as closing volume. The amount of air remains in the lungs when the flow from the lower section of the lungs becomes severely reduced or halts altogether during expiration as the small airways begin to close. This is called as the closing volume. And what is the closing capacity? The closing capacity is the volume in the lungs at which its smallest airways, that is the respiratory bronchioles, collapse. So closing capacity is equal to that of the closing volume plus residual volume. So here the closing capacity is important because it increases in the conditions like aging, COPD, asthma as well as pulmonary edema. For example, if you see that the closing pace is increased, that is, smaller airways begin to collapse at a higher volume before expiration is complete in the following conditions. So this is what we need to discuss in this module.